Hello and welcome to our latest presentation on deamination in septic shock. Septic shock, when we face such patients, we are usually faced with two choices. The first is to give fluids. We all know that excessive fluid is associated with side effects of its own. So, the other thing that can be given for maintaining the mean arterial pressure is vasopressors or catecholamines. Now, in this presentation, we will try to see what are the side effects of excessive catecholamines, how catecholamines can affect septic shock. Now, critically ill patients are frequently treated with catecholamines. Yet, these drugs have deleterious effects on immune function, thrombogenicity, metabolic efficiency, on stimulation of bacterial growth, and even it can cause myocardial injury. Now, sympathetic overstimulation during critical illness can have adverse effects. The term adrenergic originates from adrenaline and describes drugs or drugs which effect are similar to those of epinephrine. Adrenergic stress is mediated by stimulation of adrenergic receptors and activation of post-receptor pathways. Critical illness is a potent stimulus of sympathetic nervous system. Comparable to the overwhelming immune response during sepsis, adrenergic stress in critical illness may get out of control and cause adverse effects of its own. Several organ systems can get affected, and the heart seems to be most susceptible to sympathetic overstimulation. Now, the pathophysiology, the life threatening illness is one of the most potent stimuli for sympathetic nervous system stimulation. Whereas normal plasma levels of epinephrine is 0.03, it can go very high in critical illness and cardiac arrest. Now, there are various catecholamines that we are using currently. They have effect on various receptors as well. The main action for which we are using them is for alpha 1, but we cannot ignore the action on the other receptors. So this table basically shows the different catecholamines that are being used currently, that is epinephrine, norepinephrine, dopamine, isoprenaline, dobutamine, and their effect on the various receptors like alpha 1, alpha 2, beta 1, and beta 2. Now, though our primary focus is on the alpha action, the beta system is something which is important, and it gets affected with excessive catecholamines. It can affect the heart, blood vessels, the respiratory system, the digestive system, urinary, reproductive, and nervous system. Now, this shows the metabolism of the catecholamines that naturally which happens inside our body. Now, as you can see, its effect is profound and affects throughout the body. Now, once the catecholamines are released, that is from the adrenal medulla or the sympathetic nervous system, they can affect the heart, they can affect the blood vessel, causing vasoconstriction and dilatation both. In heart, they can cause tachycardia, increased energy expenditure in respiratory system. It can cause bronchodilation. It can decrease the splanchnic perfusion, alter the motility. There can be increased glycolysis, increased lactate release from liver. There is increased glycogenolysis, gluconeogenesis, increased ketogenesis. There is increased lipolysis. There is increased clot stabilization and increase in platelet activity. There is a decrease in innate and adaptive immune response, and there is an increase in bacterial virulence and replication. So these are all the effects which can affect because of increased sympathetic nervous stimulation. The metabolic alterations are profound, and the vasoactive drugs not only influence the systemic and regional perfusion, they also affect the metabolism. And it must be remembered that catecholamines may be linked with metabolic effects which is independent of the hemodynamic effects. So the increase in lactate is not always because of the hemodynamics only, it is also because of the metabolism that is getting affected. Apart from the metabolism, it importantly affects the immune system. There is a decrease in the cellular as well as humoral immunity. In the clotting system, it increases fibrinolytic activity through the beta 2 stimulation, while it decreases the fibrinolytic activity through beta 1 stimulation. So the effect is very, very complex and not very simple. So we don't know exactly how it is going to affect the clotting pathways. Now, sympathetic overstimulation during critical illness has various adverse effects, and these adverse effects are predominantly seen in the heart. So this shows the myocardial death, which is significantly higher as you're giving higher doses of catecholamines. Now, microscopically, you can see contraction band necrosis, interstitial edema, interstitial fibrosis, mononuclear infiltrates, myocytolysis, and tissue hemorrhages. So there is profound injury in the myocardium, and this may adversely affect the patient and the outcome. Although some degree of sympathetic activation is required for the survival of the patient, however, it is the overstimulation in the sepsis condition which causes the real problem, and we therefore need strategies to avoid catecholamine overstimulation, especially in a critically ill patient. Allostasis is an adaptive phenomenon whereby the body adjusts and adapts itself to various stressors. For example, exercise, emotion, hunger, to maintain a hemostasis in a systems which is essential for life. More stress will increase allostatic load, pressing greater pressure on these adaptive systems. So as the sepsis results in an increased sympathetic overstimulation, there is a decreased margin of error with the hemostasis. Thus, we need alternatives to catecholamine. The potential iatrogenic contribution of catecholamine administration to poor outcome demands further study. While useful and even life-saving short-term restoration of tissue perfusion is important, catecholamines, like any drug, may be poisonous when given in excess. So the objective of our presentation and the objective of management of septic shock is to decatecholaminize. Now, how can we decatecholaminize? We need alternatives for that. For that, there are various drugs, but currently very few have been tested in clinical scenario. Vasopressin, milrinone, levosimendan are some common alternatives which can be used as alternative to catecholamines. Now, how can we decatecholaminize during sepsis? The first is blunt endogenous catecholamine release, avoid compensatory atogenic stimulation. This we can do by optimizing the cardiac preload, treat hypoxia and severe anemia, optimize sedation and analgesia. However, all these 3 points have their side effects. To optimize the cardiac preload, we have to give fluids, which tends to cause problems. The second is severe anemia. We have to give blood products, which itself has their own side effects. Finally, excessive sedation and analgesia also affect patient outcomes. The next is to reduce exogenous catecholamine administration, that is avoiding use of beta mimetic agents. Only use inotropes if contractibility is impaired, and consider beta blockers for tachycardia which persists in septic shock. Now, the next is to blunt the inflammatory response, that is the most important, that is by treating the underlying infection and reducing the cytokine load. Now, the hemodynamic support in early septic shock. The vasoactive and potential inotropic catecholamines are still recommended pharmacological treatment even now. Although additional supportive molecules can be given, new agents and approach tend towards a new paradigm of decatecholaminization. Thus, we therefore are stuck between the scala of compromising tissue perfusion in septic shock to the Charybdis of complication of the currently recommended first line treatment. So, we need better alternatives to catecholamines, and we can include agents as diverse as vasopressin, levosimendan, or specifically inducible inhibitors of nitric oxide synthetase. So to conclude, why I want to deaminize is because catecholamines exert a negative effect in critically ill patients. So new drugs without adrenergic receptor mechanism available for inotropic support like levosimendan, which can maintain the vascular tone like vasopressin, or selective beta 1 blockers like landiolol and espoliol for reducing the tachycardia, can be used to reduce the effects of catecholamines. However, we need more RCTs to assess the effect of deaminization on outcomes in critically ill septic patients. Thank you for your patience and check our website for further information.